Upon completion of this section, the attendee will be able to verbalize and describe the most common modes of ventilation. The first mode we are going to talk about is assist control. Assist control is when your breaths are either assisted or they're controlled. The patient never ever takes a breath completely on their own. They can trigger a breath, but they will not actually take a breath completely on their own. There is a set volume delivered every time a breath is delivered, whether the mechanical or patient-driven breath. Here you will see 500 is my tidal volume. So across the board, there is 500 for each breath. There is also some dotted lines, which is the amount of time. If I have my respiratory rate set at 10 breaths per minute, that is 1 breath every 6 seconds. So here, the machine gave me the breath because I did not take a breath. The 6 seconds was up. Once again, I did not take a breath. The machine gave me that full 500. Here is where I trigger a breath. I decide that I want to go ahead and take a breath. I use that sensitivity and I pull. The ventilator recognizes this and says, that's fine, but I realize you are not strong enough, so I'm going to assist you with this. I am still getting the full 500 cc's of air, but the ventilator is assisting me. And then if I don't take a breath, the machine gives me another breath, and it is the full 500. And if I would trigger another breath in there, it would still be a full 500 cc's of air. One of the most common modes that we see in home care is SIMV, or synchronous intermittent mandatory ventilation. For this mode, the first patient trigger detected within a breath period is an assist breath. For all subsequent patient triggers within the same breath period, spontaneous breaths are allowed. At the beginning of a breath period, if no triggered breaths were given, a machine breath will be given. Breaths are given at a set minimal rate. However, if the patient chooses to breathe over the set rate, no additional support is given. This allows the patient to assume a portion of their ventilatory drive. For this one, I look at it as assist control with a bonus. The bonus is if I meet certain criteria, I get to take a breath completely on my own. So once again, I have a line here, and I have 500 as my target for ventilation. I do not take a breath, so the machine gives me the breath of 500. My time is up, so the machine gives me another breath of 500. Here, just like assist control, I decide I want to take a breath. I pull to take a breath, and the machine recognizes this and says, that's fine, but the very first breath you attempt to take on your own, I am going to assist you with. So therefore, I am given the full 500 again. Then here I go to take another breath, and it says, great, take whatever you want. I took 60 cc's. I go to take another breath, and the machine says, that's great, but it's a new breath cycle. I need to give you a full 500 to flush out your CO2. Go ahead and take another breath. You took 100 this time. I took another breath. I took 35. It allows me to finish this breath, and then I go to take another breath, and it's going to give me the full 500 because once again, I am in another breath cycle. So this is a very good mode for clients that have at least some ventilatory cycle support, and yet they can keep some of their own. CPAP. Anytime you see CPAP or BiPAP, no matter if it's through a ventilator or not, you should be thinking spontaneous. CPAP is only a supportive mode, whether it is given through a ventilator or if it's given through a CPAP standalone machine. When a patient-triggered breath is detected, pressure support is activated to help overcome the air resistance. When the patient exhales, they have a set pressure that is left in their lungs or airway to stent the airway open, preventing collapse. This is very helpful with weaning from a ventilator or providing extra support for a patient that is declining and helps improve oxygenation. So you will see with this line down here, this breathing line, that each of these breaths is a spontaneous breath. Thus, there is pressure support given to help out overcome resistance. For this one, I took 200. I paused for a while. I took 300. I took 257. I paused for a while. I took 328, 241, 486, 301. So as you can see, the tidal volumes are going to vary breath by breath depending on what I want to take. But it is a spontaneous mode. So what is the difference between CPAP therapy on a standalone machine, which is pictured over here, and CPAP through a ventilator? Essentially nothing. The patient is receiving the same therapy. So then why would I give CPAP through a ventilator, which cost about $12,000, versus a $1,200 CPAP machine? The reason why is there is one difference. A ventilator has an apneic alarm. If my patient does not take a breath on their own or trigger a breath, they will have a breath backup rate kick in and breathe for them. On a standalone or simple CPAP machine, it does not work that way. If a patient does not trigger a breath, they just will not get any breath at all. CPAP machines are also used as blowers. We used to use the air compressors that is pictured here in this picture. They are cumbersome and quite noisy. There are still some out there, but as a rule, we do not use them. Instead, we may use a CPAP machine. The CPAP machine is just being used as an air compressor or a blower. If we're using a trach dome with a heated humidifier, we are providing humidity only and no pressure to the patient. Unless the machine is directly attached via tubing to the trach itself, the air will escape around this type of a mask and not give any therapy. So therefore, if it is completely attached, they are receiving BiPAP or CPAP therapy. If it is through a trach dome or a trach mask, they are not getting CPAP or BiPAP therapy. It is being used as a blower only to provide humidification to the patient. That brings us to BiPAP. BiPAP is bilevel positive airway pressure. In other words, two pressures, bi. IPAP is inspired positive airway pressure. EPAP is expiratory positive airway pressure. Provides assistance during inspiratory phase and prevents airway closure during expiratory phase. So BiPAP alternates between IPAP and EPAP and synchronizes with the patient's breathing. Again, this is not considered life support equipment. It can only assist. So this therapy can also be given through a ventilator or through a BiPAP machine that supports itself. So how does the IPAP setting help? The IPAP you can think of as pressure support. It helps decrease respiratory muscle effort due to assist and inspiration. It reduces dyspnea, workup breathing, and accessory muscle use by resting respiratory muscles. It improves ventilation by decreasing the CO2. How does EPAP help? Continuous positive pressure maintained within the airway inflates the alveoli and keeps them open. It increases surface area, therefore improves oxygenation. It can help reverse atelectasis in areas of collapsed lung so the alveoli can be reinflated. And it also reduces pulmonary edema as interstitial fluid is forced back into the pulmonary circulation. Another common mode that we are seeing is AVAPS AE, Average Volume Assured Pressure Support with Auto EPAP. AVAPS maintains a targeted tidal volume. The Auto EPAP maintains a patent upper airway at a comfortable pressure. Auto Backup Rate applies an auto backup rate near a patient's resting rate. This can be given through a Trilogy ventilator or traditional standalone machine, and again is not considered life support. It can only assist. AVAPS works by ensuring the delivery of a constant tidal volume. The traditional BiPAP machine does not assure volumes, it just has those pressures. It uses an algorithm that estimates the patient's tidal volume over several breaths and calculates the change in pressure needed to achieve the targeted tidal volume, then slowly increases or decreases the IPAP pressure to achieve the proper pressure support. This is very helpful because it adapts to disease progression and changes to meet the patient's specific needs while achieving patient comfort. And because of patient comfort, compliance has also increased. This is really helpful with the disease progression because we cannot see what is going on within somebody's lungs. It is also helpful if we give some kind of a sedative to the patient so that they can rest. When you are given a sedative, we tend to sleep a little bit deeper, and a lot of times we don't breathe as efficient. With this type of therapy, we'll automatically adjust to keep the airway patent. Sip and puff ventilation is a non-invasive ventilation that can be used to provide portability, daytime ventilatory support. Signals are sent to a device using air pressure by sipping or inhaling, or puffing, exhaling, on a straw, tube, or wand. Patients must have sufficient strength and coordination of their bulbar muscles, and they must be able to speak, swallow, and protect their airway. Some of the indicating diagnoses are neuromuscular disease, polio, Duchenne's muscular dystrophy, quadriplegia, ALS, multiple sclerosis, and it's a non-invasive ventilation dependent patients. Some contraindications, again, are the inability to lip seal, and you have to have some neck movement and lip function are needed to be able to grab the mouthpiece. Some major benefits with this type of therapy is the option for 24-hour ventilation without the need for a tracheostomy. Because there is no tracheostomy, we also have decreased amount of pulmonary complications. We have the patient has a choice in involvement and autonomy of care. They get to make the decisions as to how they want to live their life. The infection is reduced. They still have a good cough because they have a closed airway. And they receive around-the-clock assistance. Mask ventilation is used at night, and your mouthpiece ventilation during the day. Their quality of life is much better and is user and provider friendly.